welcome Dr. Lillian Hunt tonight. So she received a BSc in molecular genetics from King's College London, and then a PhD in genetics from the Francis Crick Institute and UCL. Dr. Hunt is the EDIS program lead, and this was funded at the Crick and now works with 17 organisations across science and health to coordinate a collaborative and evidence-based approach to improving equality, diversity and inclusion in science and health research. And her talk tonight focuses on the collective achievements, actions and ambitions. So I can pass over to you, Dr. Hunt. Okay.
Thanks so much, and thanks everyone for having me here. So just as a quick note, if you want closed captions on at the bottom, hopefully there should be a little sign that says CC and you should be able to switch them on. They're not perfect because I'm using a sort of web-based system at the moment, but hopefully it can help a few people if that's what you're after. If I just share my screen as well to make sure that that's all working. So hopefully you should all see my presentation now, and it's one of those classic moments where I'm working on screens at home, so I probably can't see most of you either. So if something does go wrong, please can someone just flag it to me so I can act on it, because I won't be able to see what's going on. So as mentioned before, I'm Dr. Lillian Hunt. I am the EDIS program lead. EDIS stands for Equality, Diversity and Inclusion in Science and Health. It's a coalition of organisations. There's I think 18 listed here in the life and health sciences. They all have a commitment to improving equality, diversity and inclusion, both internally and across the sector. And that's really quite important, that this is the cross-sector sort of collaboration. It's hosted by Wellcome Trust now, so I'm a Wellcome Trust employee and housed there when we're in the office. But it was, like mentioned before, it was started by the Francis Crick Institute, Wellcome Trust and GlaxoSmithKline back. I think the idea came around in sort of around 2016, and there was a first symposium in 2017, and it's just kind of grown and expanded both in vision, ambition and size since then. So as mentioned, this sort of cross-sector collaboration really is core to our mission. It's kind of a leave the egos at the door type of approach that we're trying to promote here, where each organization knows that improving EDI is useful to them internally. It is morally the right thing to do, but also by working across the sector as a whole, across the whole of, life sciences and health STEM sector, then you're improving a whole system that everyone can benefit from as well. And it's not just those who are in the system that can benefit from this. So our vision is for everyone to have equal opportunities and access to a successful career within science and health, its research and its outcomes. And it's that last bit as well, that it's research and its outcomes. So we're not just talking about who's doing the research here, we're talking about who's involved in research as well and who gets to benefit from it. And that really kind of flows through into our sort of desired impact of equal and better health outcomes. So by having that as an impact statement, we kind of have this slightly closed off scope compared to the whole of STEM, for example, by showing that actually it's the life sciences and health sciences that you can really quickly and easily join the dots to the people who we are accountable to, because we're looking to improve human health. That kind of is a really quick way of summarizing the business case for EDI, which a lot of people talk about and ask for. You'd think that the moral imperative of equality and equity should be completely enough, but a lot of organizations, especially once you go outside of profit organizations, so outside of sort of industry, they ask for additional things around the business case, like will it make science better and things like that. And it does, but I think if we then expand it even further to making health outcomes better, you have a really quite clear and easy argument for improving a lot of this work. And like I said, it's that moral imperative though that really should underpin it all. So our mission statement is to build a powerful, connected and coordinated movement to advance EDI in science and health research. I'll probably shorten equality, diversity and inclusion to EDI quite a lot, because otherwise it becomes quite a mouthful. But that sort of collaboration, I think, is something that was really new when we started. When we did our first symposium in 2017, there were a lot of people who were working on EDI within their own organizations and across the sector who hadn't really connected before and spoken to each other, because they're working in quite sort of siloed sections of the sector, whether that's as a research funder, maybe a charity funder, maybe a research institute or something similar. But that connection and just joining the dots wasn't really happening enough. why do we need to do all of this work? Well, I mean, this slide is the best one I had to hand that demonstrates the variety of problems that there are across science and health research. So there's things around representation, so whether or not women are represented at higher levels of seniority, specifically in sort of biosciences. You have got quite a good pipeline of women coming through in undergraduate, even postgraduate research. But once you get into those higher levels, you're seeing the same sort of problems that you're seeing in other sectors as well, that sort of glass ceiling approach. In addition to that, you have other areas of discrimination and sort of barriers that exist for other people as well. So for example, less than 2% of all UK professors are BAME women, so women from BAME backgrounds. It's even fewer women are Black professors. You might have read from Nicola Rollock's report, Staying Power, sort of all subjects, but when we're looking at sort of across all subjects and including sort of all ethnic minorities, so anyone who's basically not white here, you've still got less than 2% of professors. So that problem is sort of exacerbated over and over again, depending on what your background is and depending on whether or not you see yourself in STEM and whether STEM sees you sort of in STEM as well. Something else that we want to talk about as well isn't just sort of the people who are involved in science and health research. Itself is prone to bias and is prone to sort of systems that have been built in a way that sort of retains some power dynamics across different identity characteristics. So a key example of that is thinking about sort of sex bias within biomedical research. So some of you might have read more and more articles coming out around this, around sort of the male animals in biomedical research, sort of primarily as sort of standard, with kind of this idea that it's simpler, or female mice might have more hormonal shifts. Well, that's all well and good, but you've got to remember, if this is coming to people in the end, women in the long run and will have hormonal shifts as well. And then also, in addition to that, not all of the time will those hormones actually affect the physiological attributes that you're looking at anyway. So why are we just using male mice? Why can't we use all mice? And there's lots of arguments there around sort of how you can track this back all the way down to sort of what sex of the cells that you're using in your research. Another sort of one that's taken a lot more sort of interest recently has been around genetic studies and genome-wide association studies. They've been primarily built off of patient banks that are Western European descent, predominantly white as well. And actually, if we're going to move towards personalized genomic medicine, we need to have much better understanding of genomics of the entire globe, of the entire country. And this idea that ethnicity and genetic ancestry are exactly the same is also completely confounded. Ethnicity is a social grouping that is decided upon by those who decide upon social groupings, so normally those in power. Genetic ancestries are so much more complex than that and can be traced back of many, many lineages and have no real sort of life applicability in the same sort of way at the moment, and definitely don't always sort of map over to the top of ethnicity groupings that are used and spoken about in such different ways depending on what country you're in. For example, discrete genetic groups don't exist. There's this sort of continuum in different variants will be very different. It will be important in different ways. So this is my genetics side coming out, where some of my interest in this comes from as well. And then you want to also think about the culture of research as well. Who is it that we are sort of promoting into research? Who is naturally being given those little step ups here and there? And you've got to think about socioeconomic background, for example. So in this piece of research, there was 15% of scientists coming from working class households. I don't necessarily think that language is particularly right, but that's the report that was given. And that actually is 35% of the UK population, roughly. So there's a huge disparity in terms of who's going through to research. You're looking at paying schools and sort of noble winners coming from private schools. And it's a huge proportion of people, whereas reality is not that many people go to those schools comparatively. And then think about things like culture as well. So for example, the Stonewall Top 100 Employer Index focuses on LGBTQ inclusion. And back in 2018, I think 2019 as well, there was one pharmaceutical company in the top 100 Employer Index, GlaxoSmithKline. But there weren't any other science type organizations that were there. There were sort of universities sometimes there were NHS trusts, but really sort of showing that this is an inclusive environment, and also for it demonstrating that science and health research is an inclusive environment. There needs to be more signals, more improvement in terms of making sure that people see that science is for them, and that science is also, it's a two-way street for that side of things. And the last point on there is around science communication as well, and how that underserves and misrepresents people from different backgrounds, specifically low-income backgrounds or minority ethnic backgrounds. You know, if you consider who's doing research, when it then goes to be communicated or people, without that expertise coming in from lived experience, you are going to get things wrong, and you're going to misrepresent, and you're going to, you know, have barriers between you and people when you're trying to create research. So you know, there's a wealth of different things that could be tackled here, and I guess one of the things that EDIS is trying to do is really focus down on sort of the system changes that need to happen. So you know, there could be one thing would be, you know, designing an intervention for each of these elements, but you're going to end up with sort of, you know, 100 elements of 100 interventions that you're going to be trying to sort of address all in one, and each one will move the dial a little bit, and that's great. And you know, we'll support organizations who are looking to do pieces of work in areas. The concept is, you know, what big changes need to happen, what structural changes can happen within science and health research that will improve most of these things, if not all of them, or will tackle them in some sort of way. Just a quick note on some of the data there. So some of that data is a bit old. We'll try and update some of it on the website when it relaunches as well, sort of in a month, I think it is. But as much as quantitative data is really important in EDI work, that demographics of data collection stuff, it's a way to measure symptoms of a non-inclusive culture. It's very good for flagging barriers, but it doesn't tell you what those barriers are. So there needs to be more emphasis on sort of qualitative data collection. And this is where I think us as sort of research scientists within sort of biological sciences, physical sciences, chemical sciences, we're not really taught qualitative data collection in the same sort of way a lot of the time, and the importance of it or how useful it can be. So then when a lot of the time EDI work gets given to volunteers within an organization that are sort of, you know, more sort of physical science type, you know, STEM-based individuals rather than social sciences, this whole section gets missed out, you know, that sort of collecting experiences and deeper understandings, whereas that is so necessary to really understand sort of the diagnosis element of inclusive or non-inclusive cultures. You know, you kind of see this almost like as the health of research culture. You know, what are the symptoms, what are the root causes, how can it be treated, you know, is it a whole thing that needs to change? The goal for demographic data collection really should be to use the data as one of many indicators of progress towards an inclusive and equitable science and health research sector, but also to have good enough data that new questions can be asked of it as you continue and as you go forward. So this is where asking diversity and inclusion questions kind of can be a bit of a trip up for a lot of people. So I just wanted to share a resource that we helped create last year, called the DAISY Guidance. So Dr. Emma Molyneux from the Diversity and Inclusion team at Wellcome Trust developed this guidance with support and consultation with EDIS members and with other organisations as well, for asking about various protected and non-protected characteristics by UK equality law, so including things around socioeconomic status. There's an explanatory blog, and then the guidance is downloadable at the bottom of the page. I really recommend that if you are being asked to start anywhere in terms of monitoring diversity, and both in sort of, you know, let's say people who attend events and things like that, that you start here as well, because we're trying to get as many organizations in the sector to use the same approach, and that way data sharing, data harmonization, all those sort of things can be really useful. Really, you know, making sure that you're very clear when you ask for this information why you need it, you know, this symptom checker side of things, to look for underlying problems, make sure it's anonymous. That's really important, but also you definitely need to commit to action as a result of what you find. And that's something that I think a lot of organizations haven't done enough recently, which is they collect this data, they report on it, but the pre-commitment to doing something about it, sort of no matter what it shows, that's been missing, and that's something that I hope that we sort of improve a lot. So in terms of our vision, it's everyone to have equal opportunities and access to a successful career in science and health, its research and its outcomes. And that really kind of has these three sort of big streams that kind of interlink a lot. So who benefits from research, who's doing the research, and who's involved in research. A theory of change itself that kind of surrounds this was developed to help guide our actions with an understanding that it's systemic change that's needed. So these three themes interact in a really complex system, and no single action is going to improve EDI overall. There's no silver bullet, but it's this collective, multifaceted approach that really has like a strategic vision in terms of the direction it needs to go, is the bit that's necessary. A lot of organizations previously have been, you know, looking at specific needs, driven by very clear diversity demographic data around underrepresentation, with a real focus on who's doing research. So we'd like to think of that side of things really as thinking about like the culture, education, the pipeline, the careers arm. But the perspective we're trying to take is one step a little bit away from that, thinking about sort of the wider research system as a whole, who's involved in research. I think about patients, participants, how it's done itself, you know, the actual design of research, and kind of how it all then feeds into each other in this sort of complex continuous feedback loop. Because you've got to remember that a lot of the time your first interaction with science research won't necessarily be, you know, in an education setting. It might actually be when you're maybe in a healthcare setting, or it might actually be, you know, seeing something on TV. And therefore, sort of who's then involved in research, who then helps design the research, is going to affect who then participates even further in research, who then follows research as an education stream, who then takes that into actually doing research and being a researcher, how they then shape their research. Research is science and health research is done by people, and it's done for people. So there is a lot of you know, shaping of people's research experiences by their own life experiences. So just taking a sort of a brief step about, okay, so this seems really big, you know, there's a lot of things that need to sort of change, and what sort of approach can you take to that? And some of it boils down to sort of the how we do research and how we involve people in research, but also you got to think at the very, very beginning of all of this, you know, how and funding and what are those research priorities. You know, that very first moment where you think up a research question in whatever field you're in, there's a real sort of decision point that needs to be made as to whether or not you get money for doing that research, how you do that research, and where you do that research as well. So we know there are huge discrepancies in terms of where funding goes to in the UK. You know, everyone knows of the Golden Triangle, everyone knows London Southeast gets the majority compared to its size, compared to, you know, all the other regions of funding. The other issue that you also find is that the research that's being put and the money that's going into research there in different areas, not only is it often mismatched from the actual community needs in that area, but also the actual money towards things like particular health problems might be incredibly mismatched compared to what the community of patients want for their research. So a prime example of this was the autism communities in the UK. There's a huge piece of research that was done to find out what these communities wanted support within healthcare and within social care and within research, and compared that to where money was going. And it was really striking how much money was being put into things like molecular diagnosis of autism, basically, you know, those real sort of like stripping it back down to sort of biology and really thinking about sort of, you know, what's gone wrong, basically, is that's kind of the approach that had happened, which is completely, you know, ridiculous when you consider actually nothing's gone wrong. This is just, you know, natural differences. But then when you ask the autism communities what they wanted from their research, for them it was so much more about focusing on social healthcare interventions, how to navigate healthcare, how to navigate social care, how to get early diagnosis so that there can be sort of early support put in place. And it completely shifted the way that funding was done for those communities, and sort of the way that the proportion of funding that's been sort of put into different areas. And there was also a large push for people to be able to research on themselves, kind of thing. So if you were from the autism communities, make sure that there was funding available for you to do research and you to lead and drive that research as well. So that whole phrase of nothing about us without us really kind of came through with that piece as well. Things to remember, you know, no matter what the piece of research is, no matter how complicated you might think it might be, patients and public will always have an insight for you that will always be useful. I think I've heard of a single story where someone hasn't used an effective sort of patient-public group and not found something out, something new, something different, a new approach, a new perspective, or a new connection that's been useful. And we really need to, you know, think about that when we're going forward, of removing this sort of science research cathedral sort of approach where these barriers and walls are up for anyone to sort of get involved in. And then when we think about sort of the actual research itself, so I mentioned this briefly already, but I'll just come back to it. So the sex and gender dimension in research, and this has had a lot more sort of publicity recently, because there was a book by Caroline Criado Perez called Mind the Data Gap, I think it was, or something similar to that. It was around sort of sex and gender data gaps within science and health research. It's a really good piece of work in terms of sort of explaining all of the different areas where you're finding sort of gender and data sex bias within research. But you've got to remember it also works both ways as well. So on one level, yes, sex bias within sort of preclinical research is massively skewed towards like male animal models, male cells, even the males within clinical trials and things like that until later on. But also in addition to that, you can also overly gender different health problems as well. So you can sort of, you know, emphasize things that aren't really sort of there or that don't have actual real life purpose. So things around sort of, I think there was some stuff around sort of knee replacements or heart attack syndromes, things like that, and how they've become gendered over time. But the reality is they're not in that sort of way. There are other elements that are sort of interacting to cause those differences rather than sort of it being anything sort of biological or innate. A really good site that I recommend is, so I'm working with Professor Londa Schiebinger over in Stanford, and she runs a program called Gendered Innovations, which is a US EU sort of driven piece. And we're doing a piece of work at the moment to evaluate global funders on their sex and gender and further dimensions of diversity, inclusion policies for funding. So what are they asking of researchers? Are they mandating this? Are they providing training for these sort of things? To really consider sort of, you know, inclusive research design and research practice, what is being done globally at the moment. And I think sex and gender is where the most work has been done, but it goes further than that as well. Obviously, I can't help but talk about genetics and genomics, bearing in mind that's my background. So, you know, I think a lot of people are sort of wising up to the fact that actually genomic data up to this point has been incredibly skewed, mostly towards Western white Europeans. And that in itself is a really broad brush category, but the reality is, you know, that's not the majority of the global population. Things need to be changed. And there's quite a lot of now initiatives that are focusing on increasing the numbers of people in sort of who are donating to genomic banks across the world globally to really improve the data that we have. The reason this came up for me was when I was doing my PhD, I was doing a piece of work looking at non-coding DNA, which at the time had really low quality data. And I was looking at a group of patients that had come from Pakistan. And one of the issues that came up with that was trying to compare it to sort of control data. So it was a patient group. So I was looking for genetic markers that were associated with disease, but there wasn't any sort of standard genomic control groups for the same sort of geographical region. So it was very difficult to know whether the differences I was seeing were expected or whether the differences in frequencies I was seeing were actually a result of just sort of population difference at that level. And because it was non-coding DNA, it's a little bit different from sort of coding DNA in terms of the pressures that were on it. You know, I was looking for single traits. I was looking for lots of multiple traits, and it just raised the issue. You know, it was an issue. It was a problem. We didn't know enough about it. And then you tack on top of that the fact that people continually use race and ethnicity sort of groupings and classifiers or names for groups that actually aren't based in biological realism. You know, it's being said, you know, being told that you are mixed race, for example, means nothing when it comes to genetics. It means nothing when it comes to genetic ancestries. These racial and ethnic categories and groups that we use so commonly are completely social constructs, and you will know that if you've gone to other countries and found out what's on their forms when you fill it in. You know, the category, for example, Latinx, is so large but used so frequently in America, but covers so many different people who you, if you were to ask slightly different questions, would tick different boxes. So the idea that we would then use this when it comes to sort of medical and health interventions is a real problem if we're thinking about genetics and genomics. It's useful if you want to talk about, you know, what your identity is and therefore what barriers you might have faced in terms of a social context. But when we're thinking about genetic ancestries, we kind of need to start again and scratch the whole sort of rule book up. I know that we're at a problem point where we know this now, and we're not quite at the point where every single person can have their genome sequenced before they go into the NHS system, but there needs to be something in between. There needs to be a change at this point. And then just quickly just touch on sort of involved research communications as well. So research isn't complete until it's been communicated is kind of like the dogma that I was always taught. Now, the problem is if you're communicating it in a really one-way fashion, the likelihood of it landing and making an impact is really low. And the likelihood of people believing you can be low. You know, there's mistrust that can be there. If you design the communications and the research itself with the community that you want to help or that it should help, then they will be able to take ownership of some of it as well. And it becomes a collaborative and co-production approach that can have much greater impact. And then in addition to that, you find that communities will also then advocate for their own needs, their own research needs, and their own support, and often take ownership of improvements that they want and come to you after a while. You know, if you start extending it through into sort of health and social care, you can really see some huge improvements and changes when people are put on a par with each other, not just sort of a come and talk to us and then we'll see what we do about it, a real seat at the table type of approach. So that's kind of a lot of the background side of things in terms of the things that we've been advocating for recently. A lot of those slides have come from the EDIS Symposium in 2019, which was focused on inclusive research design and experimental design. And then the other thing that we were also focusing on was inclusive conferences and events. So we're trying to do a lot of work sort of where our members can affect many different paths for that. So whether that's funding policy, whether that's training, whether that's practice and things like that, and really sort of utilizing the members for that side of things. But I think this talk's kind of one of the ones that I've started giving a little bit more as of mid last year, which is we can't ignore 2020, and we can't ignore the fact that COVID-19, the pandemic, has been happening. I've been asked quite often to give sort of a brief overview of what the EDI landscape was like sort of before 2020 and things like that, because we need to really reflect on what's happened since and how it's changed EDI and research. Because I think we can all agree that the world is not what we expected it to be at the beginning of last year, and trying to make a case for equality, diversity and inclusion when we are fighting a global pandemic, people can often say, you know, where would we put through this route? Some really slides that were by Sarah, welcome, kind of have verbatim. So, but across history have been powerful engine change, inequality distribution of health. COVID-19 no different. It's to us all that while the virus doesn't discriminate, health systems, housing systems, employment, and people do. People living with chronic health conditions have said that their needs have been ignored and that their well-being is deteriorating. Caring responsibilities have disproportionately fallen on the shoulders of women, and the impact of women within research careers, for example, is already being felt. None of this should shock us. COVID-19 has merely brought into sharper relief existing structural inequalities. But this moment should give us pause to reflect on the inequalities that exist within science and health research, that it can perpetuate, and on our responsibility to redress this. So I thought, you know, if you want to use that clip wherever you want, make sure you quote Sarah Christie, because that is her words and they're fantastic. Needless to say, coronavirus itself has taken up a lot of our time, anticipating, responding to lockdowns, potential recessions and actual recessions, pivoting of research priorities and funding. We've been in crisis mode for many months and been very reactionary, having to deal with the short-term impacts, but the medium and long-term impacts on research are still to come. We have to think a lot about what they might be and how we can act now to mitigate those in the future. There will be knock-on effects to the system as a whole. We have relied prior to the last year on productivity and measurable outputs within science and health research, within research as a whole. And reliant on a system that rewards kind of amount of work rather than anything sort of above everything else. So anyone where this has been harder for them to do over the past year will be inequitably affected. You've got to consider the impact of lockdown itself. So there's research that shows that people from BAME communities their experience in British lockdown has been significantly worse. People from BAME communities in Britain were far more likely than their white counterparts to be concerned about the impact of coronavirus on personal finances, on physical health, on mental health at the height of lockdown. There was less trusting of information on the disease from the health sector and government resources. So that's research that came out of Wellcome Trust. The Biochemical Society surveyed their own researchers and molecular bioscience researchers, and have shown that the pandemic is probably going to have the greatest impact in those at the early stages of their careers, people who are reliant on new experimental data for career progression. With early career researchers considering moving away from research as a result of this. There's concerns for the future of the funding landscape, including challenges specific to grants and sort of completing grants, as well as the idea of extensions, whether or not they're going to be done, whether or not you'll be given an extension as a result of coronavirus. I know that there are some funders who are already asking questions on their funding applications about, how has the pandemic impacted your own research? And that's great. And, it's good to see that starting, but we need to make sure that that's acted on and that policies and sort of funding is equitably assessed at this point. Research institutes have also done a lot of surveys of their staff, found negative impacts on resilience, mental health, well-being, career outlooks and productivity. I mean, that's kind of across the UK really and across the globe, but it's something to consider when you add on sort of the high stress environment that kind of already existed within research institutes. And of course, there's increased uncertainty over funding, ability to complete experiments, especially by those who've had to shield. Something also, on May 25th, George Floyd also died after a Minneapolis police officer knelt on his neck for more than 8 minutes, and that shook the world. The incident itself obviously sparked international protests against racism and police brutality. And those problems haven't gone away either. It feels now like a long time ago. We consider back to May last year, but the data and sort of the cases that have happened since then have continued. So on the slide, it's no names and cases of Black men and women who've been killed by police in the US so far this year. Now, in the UK, entrenched racial inequalities also exist and have been laid bare. We have our own history to face up to, as well as our present, and we need to understand how that history has been written, edited, and propagated by those with power and privilege to do so, and often in a way that intends to continue that power dynamic. This is true in science and health research. We are constantly told that science and health research, is explicit and it's very sort of, done without a human lens. But the reality isn't that. The reality is science and health research has always been done by humans who are a product of their time, by humans that are a product of society, and by humans that will have viewpoints that come into the research itself. People talk a lot about decolonizing STEM or decolonizing academia. And one step, for example, is digging deeper, uncovering truths about who has contributed what, where, which names have been omitted from history, for example, but also which approaches are rooted in racist science, and therefore changing the way that we work and research and teach to reflect that as well. But it also means breaking down the structures that maintain that status quo. And the research and academia have a lot of these structures. The cathedral of science, I mentioned it earlier, is so reliant on prestige and narrow definitions of excellence that not only does it make it difficult for a lot of people to sort of access that and get through and be successful, but of course, once you are successful within that structure, there are very few incentives to break it down and rebuild that system, the system that will now prop you up personally. We're reliant on waves of effort from the masses at grassroots level, but also we are hugely reliant on senior leaders, directors, professors to not pull up the ladders behind them and use their privilege to change the system while they're at the top. And in addition to that, we really need them to be willing to say, it would have been more surprising if I'd failed, because the reality is it would have. So EDIS for sort of 2020, so its members have been some pivoting of priorities sort of individually, but as a coalition, we also set common goals and themes of work to focus on to create larger waves of change across the sector. So our membership is really broad. So trying to think of things that each organisation has access to a part of to change. So we're having lots of different dials changed, but all in the same direction, I think is really essential. So over the past year or two, we've been looking at inclusive research and experimental design, which I spoke quite a lot about at the beginning, and inclusive conferences and events, which has had a lot of change over this year, obviously, as we pivot to online events. There's a lot of work that needs to be done in terms of capacity building and retraining for researchers, thinking about, how do we make sure that what we're asking for is something that people feel confident to do. And then inclusive meetings and events, it feels like it's been a wave of change around speaker selection, venue accessibility, now online venue accessibility, sharing a good emerging practice, but also experimentation as well, trying new things out and being willing to report when it's worked, when it hasn't worked. Something that kind of got flagged to me, actually, bearing in mind I have my own internet and Wi-Fi problems, is actually, yes, online events could be more accessible in terms of geographic location, but are you willing or able to pay for data packages to allow people to sort of attend, things like that you might not think about in the first instance if you're sat with a super fast broadband somewhere in London. There are lots of people globally, especially, who will not be able to access fast internet, that will not be able to keep up with many video calls, many video presentations, especially when you start adding on sort of multi-room networking conferences and things like that use up so much bandwidth. So there's still progress to be made even now that we move online to accessible, more accessible online events. Quickly as well, with COVID as well, it is a clear example of how research in health needs to be inclusive and representative, so that interventions and policies involve communities they're trying to help and have an impact so they succeed. We've got to remember that research we do, no matter what field you're in, it will get taken up somewhere into a policy or intervention or healthcare intervention or technology that will affect people in the long run, and we can't forget that. So that sort of that long-term impact is something that researchers are often asked when they're thinking about sort of funding. What could be the great thing that could change as a result of this? But you also often forget that you might not be in control of how your research is used. Someone out there, whether it's media, whether it's someone else, will take the research however you've presented it and roll with it in the direction that they have chosen to go. So we really need to make sure we're presenting sort of the fullest picture that we can when we present our research as well. So yeah, with this year, things that we've learned, I think there's still some questions that we now need to sort of pause and ask ourselves. Working remotely or home from during the pandemic within research, especially either if you're a lecturer, if you're a researcher who normally relies on lab time, if you're a researcher who can pivot quite easily to online, are you a bioinformatics researcher? How has that worked for you, and how has that worked differently for each other as well? There was lots of messaging around being kind to yourself, employee mental health and well-being gained lots of publicity and momentum, but was it actually done right? Was it just words, or did you actually have that support there as well? The pandemic itself highlighted and exacerbated pre-existing health and social inequalities. It's a public health issue with huge ramifications for social welfare, and a social welfare issue with huge ramifications for public health. A lot of existing inequalities mapped onto increased exposure risk, susceptibility to disease, severity of illness, response to treatment as well. And that kind of leads into the decision making. The way the world, governments, employers, your organization, university, how do they respond to the pandemic? Was decision making itself inclusive? Was there differential impact on who was given furlough or not? How does that affect research? I've put medical research here, but it could be any research. And then conferences, events, like I said, how can we have a long lasting positive effect on inclusivity and accessibility? This is just a very brief slideshow. That there has still been a lot of EDI work been going over this year. It has felt like one of the busiest years within the sector, within science research as well. Responding to the pandemic, responding to sudden changes, responding to social justice movements, and making sure that we're using the waves of momentum that occur, but also making sure that we've been plowing on with this work for years prior to this. I know that there's been anti-racism work programs that have been in the pipeline for sort of 6-12 months, being done correctly. And then George Floyd's death in May sparked sudden reactions from a lot of organizations that meant that had to be shifted really fast, turned around. And on one level you're thinking, brilliant, this work is now getting the momentum and the attention that it deserves. And on the other level, you're kind of disheartened by the fact that it's taken something like that for this work to get the attention and direction that it deserves. So there's been loads of sort of difficulties, I think, with people working within EDI within science as well, with sort of that separation of sort of the personal side of things, of trying to be there for everyone at the same time as trying to do the work-based side of things. and just sort of considering, you know, what we can learn from this within the EDI agenda, especially within science and science health research, is, you know, being actively anti-racist, I think, is primarily something that everyone can go away and do. You know, this, if you look up the longboat analogy, you know, imagine there's a longboat, it's going down a river with the current, you know, that's the direction of, for example, racism. You've got people who are rowing in that direction as well. It's not enough to just stop rowing. You need to stop rowing and row the other direction and get everyone else around you to do the same as well, to fight against that current, because at the end of the day, the systems that are built is, you know, the version of that current which is towards racist structures and racist policies. It's part of our history that we need to, you know, really act on at the moment. We've needed to act on it for a while, but the momentum's there now for the shifts to happen. And that kind of leads on to that understanding the social context of the world that we live in. It can both limit and influence the way that we do this work. It limits and influences the way that we do science research, and the way that that's then taken on by people into policy and into practice. Obviously, I think this year's shown last year's shown an increased empathy and flexibility, in need for increased empathy and flexibility for people in different situations. And the number of Zoom calls that I've phoned into where someone's got, you know, either someone they're caring for, whether it's a child, whether it's an adult, whether that's a pet, you know, whether there's bad internet, whether there's good internet, whether someone just literally cannot be in work on their computer at all. You know, there's so many different situations that have happened. We always talk about separating home and work life, and that's been impossible for the past sort of year or so. There's also a need for a greater diversity in decision making. So this is, you know, bringing those voices in, again, seat at the table, making sure that people are, you know, their voices are heard and acted upon as well. You know, lived experience is expertise through experience, and the experience of barriers due to your identity, due to your background, that informs your approach to developing solutions. That's so essential for developing solutions that work, and also identifying issues before they arise. And the last one, equitable solutions for equal outcomes. You know, not everyone will need the same solution, but what you want is the outcomes to be the same, which means that some people might need more support than others, and that's absolutely fine. And positive action is legal in this country, and it is recommended from UKRI did some equality, diversity and inclusion intervention reviews, and positive action was one of the biggest of successes that comes out of that, and is something that was worth looking at. So just sort of to finish up, just thinking about inclusive decision making, you know, especially in light of, for example, the pandemic. An example of this is the difference that people experience risk and resilience. So any decision where risk is factored in disproportionately affects those who are, you know, in higher risk groups, or live with people from higher risk groups. And now there's an overlap. There was an overlap last year of this in terms of COVID-19 with those who are already from marginalized and minoritized groups. Risk itself is unequally distributed, felt and perceived, and resilience is unequally distributed, felt and perceived. It's a factor of the social context we live in. It's affected by, you know, physical and emotional burdens of racism, ableism, and other forms of discrimination, in addition to sudden stresses, for example, COVID, pandemic, furlough, you know, and lockdown and things like that. So how do you then, you know, take an example like this and think about, you know, all forms of maybe sort of healthcare interventions, decisions and policy making, and consider how to sort of create sort of inclusive decisions and returning to normal decisions from this. And this is just sort of an example is, you know, think about trusting in people, trusting in staff, sharing agency of choice, consistency of approach, clarity of options, you know, consultation. All these are essential, and these can be used for any policy decision, any EDI policy decision, especially sort of in workplaces, in your university. You know, people should have agency to make choice. People, you know, should be trusted to make the right decisions for them. You know, senior leaders and managers and everyone need to have the consistent of messaging and approach. And the consultation with staff networks is really important as well, you know, including those voices of people, but acknowledging the additional labor that has. And then sort of the clarity of options, specific, explicit, unambiguous, but equitable as well. So, you know, an inclusive policy really is one that has the flexibility to support people in different scenarios, and getting that balance of standard approach for fairness with enough flexibility for situations that you wouldn't ordinarily come across, which is why it's also essential to involve people that you're making a policy for in its design, so it can work for them. And you also learn a lot about what typical application scenarios and barriers could be. And this approach for inclusive decision making can be done all the way through the research cycle as well as policy around research. So it's, you know, it's thinking about how, you know, how you can implement this in any policy, any inclusive decision that needs to be made. But just to finish up, you know, what we've learned from this pandemic, for example, could be the actions and policies that we put into place for equitable assessment of research, for example, for equitable support for research careers. You know, how do we measure outputs? These changes could be a permanent fixture. So we have an opportunity to get this right. You know, where we see changes, for example, to the workforce based on this crisis moment, really indicates where the system was weak already, and where there has been exclusion, and you know where in terms of inclusion there needs to be improvements. So we really need those sort of stable and consistent commitments to D&I that aren't reliant on individual champions, and really sort of solidify these pipelines of support for each other. So with that, I think it's probably time for me to close up. Just going to finish and leave some sort of links on the end there for people to have a, you could screenshot those, probably be easiest at this point. But I think it's Q&A maybe at this point. Thank you.
Thanks, Dr. Hunt. Really interesting talk. Some really brilliant work that's been done. I was really impressed and interested in because it's something I would never really thought of, but the questioning the groups that want the research, like you said in the autism study, where, you know, yeah, sometimes scientists have this single-mindedness of let's figure this out, when actually the people aren't benefiting from it. Yeah, geez. So that was really interesting. I've opened up the chat again, so if anyone wants to ask any questions, or if you just raise your hand and I'll unmute you, or if you want to unmute yourself. We had a question earlier on from Susan, where some people have commented that some doctors do not consider that there should be different treatments for men and women with the same disease. I guess, does that kind of fall into?
Yeah, I mean, I think there's an issue. There's issues where we don't have either good enough research and understanding of where differences do exist. It's very difficult to then sort of, you know, indicate some sort of healthcare pathway that could be different. But there are elements that we do understand that do have an impact, and there's three real elements kind of to the gender interaction, let's say, within sort of health outcomes. And you've got your own identity itself, kind of the identity or how that you are perceived as, or sort of how that's approached. There's an interaction between those two, and then there's an interaction with the gender of people around you as well. So clear examples being sort of around things like pain management within health research. You know, women and men are treated very differently based on pain that they present with, both between themselves, and sorry, this is quite binary in terms of gender at the moment, but that's where the research kind of has got to. But they're treated very differently based on whether or not they're a man or a woman, and in addition to that, whether or not their doctor or physician, because it was in the US, is a man or a woman as well. So there's that interaction that happens as well. So there's lots of interesting elements, and I think that's where the social implications have more of an impact than sort of maybe a biological feature at that point. And that's something that I think we're kind of in this situation sort of in society where we're looking for biology as the answer pretty much all of the time. And it is fascinating. And there are plenty of areas where there will be significant differences, but significant differences, the question is whether those significant differences are small significant differences, as in consistently small, or whether they're sort of large differences. And I think that's where people get sort of that mix, where it's like actually a lot of the time there might not be quite as big differences, and you can sort of think about the social implications that result in different health outcomes rather than the sort of biological.
Yeah, wow, thanks. We've got a question from Medina, if you want to unmute.
Hi, yeah, thanks. That was a really great talk. A lot to like think back on. I was really intrigued by what you were saying with regards to how academia and kind of research systems themselves have so many of these biases ingrained. And I guess wondering, you know, what do you think of working with organizations or like individuals who are kind of outside of the system? Is that something that EDIS is working on, or kind of other people within EDI are working on?
Yeah, so we don't have any sort of strong connections in terms of outside of academia at the moment, but it's something that, you know, I always want to improve upon. I guess the way that we've kind of worked the membership at the moment is thinking about who can enact on the system itself, and the next stage, I guess, would be completely, you know, changing the system. And there's been quite a lot of great talk around sort of exploding this idea of excellence. You know, what is scientific excellence? Because it is so narrowly defined. It is so sort of entrenched with sort of a historical perception of what excellence is, and there's no point us pretending like that doesn't define how we measure people's research outputs, people's research abilities, and people's scientific abilities now, and also defining who gets to be a scientist or who gets to be an expert as well. You know, that all comes through in the same system. And I'd much prefer to speak to people, you know, who are maybe outside of that system, who can see a better way. It's a case of now, how do you bring those two groups together so that those who are sort of in the system and benefiting from it are willing to give it up? And I think that is one of the hardest things, is trying to get those people who really sort of, who have made it through to the top or are near the top or something like that, and getting them to say, actually, the system that has brought me to this point is full of biases and it does need to change. The only people that I've kind of got to do that at the moment are people really senior who are like on the verge of retirement because they've got nothing to lose kind of at that point. But then they've started to get a couple of people who are willing to, for example, you know, use their power and say, look, I won't be on this board if you don't do this, and things like that. But it's kind of because they're on their way out as well. So it's a tough one to do. Thank you.
Do we have any more questions?
Yeah, if you don't mind me asking one. You mentioned a couple of times throughout the talk about how there's a slight skepticism towards, say, advice from the NHS. What are the current plans in place to try and amend that?
As in sort of healthcare advice around COVID specifically?
Or
yeah,
so as well, if you don't mind.
Sorry, what was that? Sorry.
Or in general as well, if you don't mind answering
in
that.
general. Yeah, to be honest, I don't know enough about what the NHS is planning to do as a result of this. I know that the NIHR, so the National Institute for Health Research, so thinking more the research arm of it, they are releasing a new set of, so they have public and patient involvement standards now. So that if you want to use public and patient involvement, there's standards there, which will benefit the communications, which will benefit that side of things as well. The NIHR as well is creating a new values framework that will be released, I think, this year as well. And I think there'll be a large underpinning of that as to how to involve research communities within the research, so that then the skepticism sort of like goes down again. And we've started to get a few more good sort of case studies of where that's been done really well. So there's a group out of Leicester who work on health inequalities, specifically BAME health inequalities there. And I think it was their group, or at least they were in collaboration with someone who did a great piece of work on, I need to get this very right, on communicating the risk of prostate cancer to African Caribbean men, I believe, in the local area, through using community-based learning and engagement, which was the Dominoes Club there, which was a fantastic piece of work of really co-producing a health intervention with a community, so that it really landed with that community, and using like local figures and people, you know, to be involved in that. And you know, there are a couple of sort of these examples that are sort of floating around now that really kind of coming together a bit more through the NIHR to show sort of how you can improve that. So that's kind of where my knowledge comes on that side of things. Thank you.
No, thank you very much for that answer.
Can I ask a question?
Yeah.
Thank you very much for your talk. It was really interesting. I was wondering if you could maybe explain a bit more about how you undertake the qualitative studies, because as a chemist, we really don't do that. So I was wondering how you get scientists to undertake that side of the research.
To a certain extent, you don't get scientists to do it because we haven't been trained in doing it. So the best bet would be to really collaborate with a social science researcher, someone who has the really in-depth experience of this. We have some researchers within Wellcome Trust where I work, you know, who have been able to support massively on qualitative research, on interviews, on coding and that side of things. So if you haven't been trained in it, I really recommend, you know, it's either get some training in it as well, but also collaboration with social sciences. There's a lot of stuff around diversity and inclusion and equality and equity work, that the social, behavioural and humanities sciences have been doing for a long time. And when you speak to researchers from those fields, they're like, well, yeah, we've been talking about these theories for, you know, years, decades even. So that collaboration really is important to sort of help drive that work through. But yeah, collections of, you know, interviews and experiences. So like I said, you know, Stay in Power by Nicola Rollack is a great report on Black female professors and their experiences and their experiences of how to manage the system and succeed in it. And that was a really great piece of qualitative research that was done. There's more research that's been done. So another one, so the Wellcome Trust did a Reimagine Research research culture report, and that had both quantitative and qualitative research. So that's a really good example of seeing the two sort of together to prop up sort of the arguments and sort of the experiences that people have. But yeah, especially when you think about sort of collecting data around researchers themselves, a lot of the time the numbers of people within sort of some of these groups, you know, groupings, once you go down sort of real granular detail, are really low. You know, the number of UKRI funded Black PhD students is unreportable because it is so low. So you have to then try and figure out ways of speaking to people to really understand the experiences if you don't have any data to pull on. Because one, firstly, the fact that you have no data should be a huge argument, but you need to figure out why and what those barriers are and what those solutions should be. And a lot of the time people in those positions are the ones that will tell you the solutions too. Thanks.
Thank you very much.
Yeah, super interesting, and something actually can relate to from going from kind of science research to then more kind of teaching social science. It is really difficult, and you're right, you need these kind of experiences rather than just cold hard numbers. So I'm going to pass over to, thanks everybody for your questions. I'm going to pass over to Chiara, and she will pop us through to some breakout rooms if everybody wants to stick around. And yeah, if there's any further questions, maybe we can chat there.